Is my screen visible?
Yes, ma'am.
Yeah. So I think we are okay with the slides.
Yeah. Ma'am,
Okay.
you can stop
I will
sharing now
stop
because we
sharing.
are
Yes.
live
Yes.
now. Yeah.
Yeah. Okay.
Ma'am, shall I start the first slides?
Yes.
Yeah. Thank you, ma'am.
So, shall I start? Yes?
Yeah, you can start, Madam Sushma.
Yeah. So, namaskar. मी डॉक्टर सुषमा सावे, को चेअरपर्सन ऑफ बाल सखी संजीवनी आणि सगळ्यांचं स्वागत करते आहे. बाल सखी संजीवनीने हाती घेतलेला हा उपक्रम डिबेट दांडिया ही एक चांगली टीचिंग आणि लर्निंग मेथडॉलॉजी आहे आणि ह्याच्या संकल्पनेचा उद्देश असा आहे की जे काही आपल्याला गोंधळात टाकणारे प्रश्न आहेत त्यांचे उत्तर शोधणे आणि ह्या उपक्रमामध्ये आपल्याला त्या विषयातले 2 तज्ज्ञ मार्गदर्शन करतील आणि ते 2 तज्ज्ञ त्यांचे मार्गदर्शन झाल्यानंतर एखादा प्रश्नाचे उत्तर शोधण्यासाठी किंवा जे आपल्याला डाऊटफुल प्रश्न आहेत त्याच्यावरती वादविवाद करतील आणि त्यांचे मार्गदर्शन संपल्यानंतर आपल्याला एक्सपर्ट त्यांचे कमेंट्स देतील. तर असा हा उपक्रम आहे आणि ह्या उपक्रमाचं आज आपण सगळे जमलो आहेत की आज वर्ल्ड अनेमिया अवेअरनेस डे आहे आणि त्याच्या संदर्भातला आपला आजचा टॉपिक आहे की इज आयर्न डेफिशियन्सी अनेमिया ओव्हर डायग्नोज्ड इन इंडिया. तर ह्याचे सूत्र मी डॉक्टर रुपालींना हाती देण्याच्या पूर्वी आपले जे काही मान्यवर उपस्थित असतील त्यांना सांगेल की आमच्या ह्या उपक्रमाबद्दल आम्हाला थोडे मार्गदर्शन करावे. आपले लाडके महाएपी अध्यक्ष डॉक्टर संजीव जोशी सर आहेत. रेणू मॅडम.
Yes, sir.
Sir is there. Sir is there.
So can I request
Yes,
sir?
I am there.
Yes, sir.
Good
So can
evening,
you just
Sushma. Good evening.
Yes, sir. So can you just give us a words of wisdom, sir, on this debate Dandiya?
So, a very pleasant evening to all. प्रेम दिनाच्या पहिल्या संध्येच्या तुम्हाला खूप खूप शुभेच्छा.
मला सुद्धा
आणि मला असं वाटतं की प्रेमाला काही दिवस लागत नाही. प्रेम इज 24/7 and till your last breath. So, सर्वप्रथम I must congratulate the team Sakhi Sanjeevani for accepting our request to uh, celebrate this Anemia Awareness Day. Anemia is the subject which is very, very close to my heart. I think anemia and iron deficiency is not just a deficiency of hemoglobin, but the cohort 6 months to 2 years, they are the most vulnerable population so far this iron deficiency is concerned. Because iron is not only for hemoglobin, it is also for the maturation of the brain at all level. And the kids, when the newborn is born, the growth of the brain is continued till almost 3 years. And what happens? The science says that the iron, which is a very important micronutrient, the source from 6 months onward should be from the weaning food. And the tragedy in India is that whatever weaning food is given above 6 months to 2 years, they are very much lacking in the iron. Or on the contrary, some of the foods like cow's milk, they decrease further decreases the iron level, and that is very detrimental to the brain growth. It has been proved in the animal studies that the mice which are fed with the iron and which were not fed with the iron, the brain growth was definitely differs a lot, and it has got a direct correlation with the cognition and the DQ in the adolescent level. So, my humble request that the expert should guide about this particular cohort also, not only the preschool or the school going age group. And the iron deficiency is prevalent in all socioeconomic groups. तर आता बालसखी संजीवनीच्या समस्त पदाधिकाऱ्यांना माझा माझ्या खूप खूप शुभेच्छा. सेक्रेटरी रेणू, आजचे दोन्ही एक्सपर्ट्स आणि अवर ओन गर्ल रुपाली. She will be very much action today. Jayashree, Sushma, and Shilpa and entire team of Bal Sakhi. I have given request. I have put an humble request to all the office bearers of the district branches that this is a very unique subject and community oriented subject. So I hope the number will definitely swell. So just I am winding up my Shubhecha. So enjoy learning and enjoy the dandiyas. Thank you.
Thank you so much, sir. May I request Dr. Renu madam to say a few words, please?
Yeah, good evening, one and all. And we are very much happy that Bal Sakhi Sanjeevani has taken this National Anemia Awareness Day for World Awareness Day for the occasion to present the debate Dandiya today with Dr. Amit Jain. Welcome to this group, and also Dr. Lisa, welcome, and Dr. Sangeeta ma'am, who is the expert today for the judge. And I think there should be a Vad Vivad Spardha in this, we should have our tone up and down so that it likes to be real in the settings like the role play. So apart from this, as we know that this is the 6 by 6 by 6 of the anemia mukta bharat by the government of India, where there are the 6 target group, where the 6 interventions in the form of supplementation of iron, folic acid, with deworming, behavior change, communication, anemia testing and treatment, and food fortification, and addressing the other causes like malaria, fluorosis. Malaria nowadays it has been down in many parts of Maharashtra, at least apart from Mumbai, and enabling the systems in the 6 various ways. So that is what the 6 by 6 by 6 is there. And we know that we should raise the hand for the blood health. That is the slogan theme of this year, and that's what we everywhere in India, as well as today, yesterday we had a forum for the national level by Dr. Neelam Mohan madam, where our international participation with the Sri Lankan team was also there. So it is the Southeast Asian countries which are mainly anemic in this as per their data also. So I think I should not bias the debate. So we will start with it towards to you, Sushma ma'am, for the further proceedings, and also to Rupali and Jayashree madam.
Yeah. So thank you so much, ma'am. And I really acknowledge my colleagues also, Dr. Jayashree Deshpande, madam, as a chairperson of a Bal Sakhi Sanjeevani, and Dr. She's a convener. So with this, I think we should, without wasting much time, we should start. And I request Rupali, madam, to take over as a moderator. Thank you.
Thank you, madam. Good evening. To welcome is to show honor, and to welcome is to establish intimacy. So I take this privilege to warmly welcome Team MAHA 2026 and to all the dignitaries of Central IIP and respected members of IIP. And I thank you all the EBs of MAHA for giving me the opportunity, and especially Dr. Jayashree Deshpande madam, chairperson of Bal Sakhi Sanjeevani, for encouraging me. So today is the second episode of our series Debate Dandiya. And on occasion of World Anemia Awareness Day, we continue our focus on blood health with the theme Raise Your Hand for Blood Health, reinforcing efforts to reduce anemia among the children, women, and adults. So today's topic is iron deficiency anemia in India is overdiagnosed. So iron deficiency is an important public health problem, especially in developing countries. The most common cause of iron deficiency anemia observed in children include inadequate intake together with a rapid growth, low birth weight, and gastrointestinal losses due to excessive consumption of cow's milk. So IAP runs a major nationwide anemia initiative called IAP की बात community के साथ to support the government's Anemia Mukt Bharat mission. And IAP has introduced a mobile units Bye Anemia buses to visit schools in rural area for on-site screening and to provide medication to children found to be anemic. So we have two Dhurandhars for today's debate. And our first Dhurandhar, first speaker is Dr. Amit Jain sir from Mumbai, and he will be speaking for. And his topic is most children have physiological or infection related anemia. So sir has done fellowship in pediatric hematology oncology and fellowship in BMT. He's consultant at Sunact Advanced Therapies and PD Hinduja Hospital and Medical Research Center. Sir is an editor of evidence-based IAP, PHO National Guideline for the Diagnosis and Management of Thalassemia 2023. So may I request Dr. Amit Jain sir to take over.
Thank you, ma'am, for the kind introduction. I'll share my slides. So next 10 to 15 minutes, I'll be talking on iron deficiency anemia, overdiagnosed in India. So most of you are aware about the prevalence of anemia in India. It is very high in young children's. I'm talking of anemia, not iron deficiency anemia. It is very prevalent in all the age groups ranging from 40 to even 67%, which is also mentioned by National Family Health Survey 5, in which children between 6 to 59 months of age have very high prevalence, up to 67%. We are talking of anemia, not iron deficiency anemia. When I searched on Google the prevalence of iron deficiency anemia, even the AI considers anemia as iron deficiency anemia, not a iron deficiency. So we don't know what is the exact prevalence of iron deficiency anemia. There are literatures which are based on certain parts of India, but not like NFHS survey, which says that prevalence of anemia is 67%. So currently we are not aware about exact prevalence of iron deficiency anemia in India. NFHS measures hemoglobin, but it does not measure ferritin, vitamin B12, folate, or CRP. So it reports anemia prevalence, but not iron deficiency anemia prevalence. So in India, even most of the policymakers, or I may be harsh, but it is the fact they consider anemia as iron deficiency anemia. Anemia can be multifactorial in Indian children because of recent infections, because of inflammation, other causes like hemoglobinopathy and other nutritional deficiencies, including vitamin B12 and folate deficiency. Yet low hemoglobin is considered as iron deficiencies, is our defaulted assumption. So we diagnose iron deficiency based on hemoglobin values, but not based on iron studies. Even the WHO says that iron deficiency anemia accounts for only 50% of the anemia. Rest 50% are other causes of anemia. So iron prophylaxis was initiated in India since 1970s, but this is the iron prophylaxis paradox. Despite giving iron prophylaxis, the prevalence of anemia is rising. Why it is rising? We should know the cause. So to dig into that, the survey was done in between 2016 and 21, and they found that maternal anemia was the strongest predictor. The rise which was seen during the 4th and 5th survey was seen in across all wealth groups, and it suggests that there are drivers behind simple, it is not simple iron deficiency, but there are certain other drivers which are leading to anemia in these populations. So if iron deficiency were the primary cause, 50 years of iron prophylaxis should have shown sustained decline, but not reversal. So this was the survey. This was the paper in Nutrients based on the survey done by Comprehensive National Nutritional Survey, and they found that 50% of the patients have other causes apart from iron deficiency. The causes included are either vitamin or B12 deficiencies. That it could be dimorphic anemia. In some patients, it is anemia of inflammation. especially between 5 to 9 years of age, the predominant cause is vitamin B12 or folate deficiency. And what they have noticed that more than 50% causes in across all the age groups are other causes than iron deficiency anemia, the causes which I have mentioned earlier. This was also the part of survey in which iron deficiency and anemia, but not iron deficient population is equivalent to iron deficiency anemia in certain age group, and between 5 to 9 years of age, it crosses the other causes crosses the level of iron deficiency. So physiological anemia is often mislabeled as a pathological anemia. We do not have cutoff of labeling iron deficiency anemia less than 6 months of age, and often this is the physiological anemia of infancy or newborn, which we are treating as iron deficiency anemia. Other is, especially in adolescent group, dilutional anemia during the growth spurts, also labeled as iron deficiency anemia. So these are treated as iron deficiency anemia without confirmatory diagnosis, and we are medicalizing physiology. So we all know physiological anemia of infancy, that based on the gestational age and the timings, there are based on the gestational age, the range of hemoglobin based on the timing of nadir. So it has been addressed properly, but the causes included here are decreased production of RBCs, lifespan of reduced lifespan of fetal blood cells, and rapid growth, which causes dilutional anemia. So since we do not have cutoff of iron deficiency anemia less than 6 months, this is the paper from Brazil in which they try to find out that what could be the minimum hemoglobin to call it as to call it as physiological anemia. And the cutoffs here are between 7.5 to 8 for at hemoglobin, which they were calling as physiological anemia. So if the child has hemoglobin between 7.5 to 8, we are mislabeling as iron deficiency anemia and treating them as iron deficiency anemia, but it is physiological anemia. This was also one of the paper from California in which they try to get the cutoffs for hemoglobin, MCV, ferritin, and transferrin saturation, and they found out that the cutoffs are different for different ages. So diagnostic criteria for iron deficiency and iron deficiency anemia in infants are very poorly defined. And in general, anemia screening to detect iron deficiency is not indicated less than 6 months of age because infants usually have adequate iron nutritional status. This is from the CDC guideline, which they are quoting that physiological anemia is physiological and the newborn or infants have adequate iron status. And it is not related to maternal iron because neonates are parasites. They absorb all the ions from the mother and become sufficient in iron status. The second cause is infection-related anemia, the pathophysiology, which we are aware that infection leads to increase in interleukin-6, which leads to increase in hepcidin. And this hepcidin blocks the iron absorption from the gut. Thereby, this iron gets trapped and causes functional deficiencies in children. So it is commonly India in India there are some tropical infections which are prevalent across the India like malaria, dengue, and some other infections. Very high prevalence of environmental enteropathy, tuberculosis, and parasitic infections, which can lead to anemia in the child. These are the differentiating parameters between iron deficiency and infection-related anemia, which we are aware. In India, the recurrent infections are common and many children have transient inflammatory anemia. If ferritin is not low, CRP is high, calling it iron deficiency anemia is actually incorrect. So this was the paper in children in which they, around a lakh of children, several children, and they found out that in these children, based on the CRP values in even the infections, there is significant reduction in hemoglobin ranging from 1 to 2 gram after infections, which has been recovered once they are cured of the infection. So this is one of the parameters which can lead to drop in hemoglobin with the infections. The third and other cause, which is not the part of debate, is vitamin B12 or folate folate deficiency. In India, it is one of the highest vitamin B12 deficiency burdens in the world. Yet anemia program is iron centric. So prevalence ranges from 30 to 70% in children and adolescent age group, and in pregnant women it is 40 to 60%. Still, majority of the population of India is vegetarian, and because of which the vitamin B12 deficiency is very prevalent. So why this matters? Why we are debating here? Consequences of iron only approach, macrocytic anemia or dimorphic anemia can be missed if there is B12 deficiency is missed and we treated them with iron supplements. There is chances of neurological damage in these children, and poor response to iron we often label them as non-compliance. So Anemia Mukt Bharat actually treats anemia prevalence, but not anemia etiology. And when policy assumes it is iron deficiency without measuring B12 or folate, overdiagnosis of iron deficiency anemia is inevitable. Some other parameters like ferritin, which is unreliable because it is an acute phase reactant, and children often come with infections when they have anemia. And at that time, we do ferritin, which is actually false reassurance or false diagnosis of iron deficient, false reassurance. Other thing is all microcytic anemia is not iron deficiency anemia. India has prevalence of thalassemia rate in the range of 3 to 4, and in certain communities it is up to the tune of 10 to 12%. So many children get years of iron without hemoglobin improvement, and we label diagnosis was missed. So we are treating thalassemia trait with iron and labeling them as iron deficiency anemia. So giving iron, it can cause harm like GI intolerance or poor tolerance. So suppose a child is on other medication because of iron GI intolerance, he is not able to take other medications. Iron overload in hemoglobinopathy, especially chances of missing malignancies and other marrow failure syndromes, and ongoing neurological damage because of vitamin B12 deficiency. So I'll close here by saying we don't overdiagnose actually iron deficiency anemia, but we are under investigating anemia. Treating every child with iron is not a public health. It is a shortcut to treat anemia, and anemia deserve diagnosis, not assumption. Thank you.
Thank you, sir. That was a truly engaging session. And now it's time for our second Dhurandhar speaker, Dr. Lisa ma'am. She's speaking against, and her topic is iron deficiency anemia remains grossly underdiagnosed and undertreated. So madam has done her fellowship in pediatric hematology, oncology, and BMT. She has many publications and 5 patents. She initiated 3 comprehensive thalassemia daycare centers across Maharashtra, that is in Pune, Ahilanagar, and Amravati. She plays an active role as a part of the National Task Force for Advocacy of Childhood Malignancies and Bone Marrow Transplant Survivorship Program. So over to you, madam. Lisa ma'am.
Hi, thank you. Thank you, ma'am, for the very vast description. And I thank MAHA and Debate-Dandiya for giving me the opportunity to have debate with Dr. Amit, who is my co-fellow. So after 6 years, I'm going to fight with Amit today, and thank you, Debate-Dandiya, for that.
So you have got a good history, past
Yeah,
history of
very good
fighting
history.
with Dr. Amit.
Yeah,
But
madam.
I am happy that his voice was consistent. He was not in the fighting mode.
No, madam, that will come in the rebuttal session. Madam.
Yeah, we are waiting for that.
Yeah. So Dr. Amit has already convinced me that we are overdiagnosing. So okay. Are we able to see my slides?
Yes,
Hello?
yes.
Yeah. So today on World Anemia Awareness Day, we are having a debate if we are overdiagnosing the iron deficiency anemia, and my point of view is currently against. I think Sanjeev sir has mostly covered my slides when he gave the intro, but I will try to bring a little justice over and above whatever has been discussed till now. So when we say 67.1 prevalence overdiagnosis is already out and under recognition is becoming the epidemic. And it is 8.5% more than the last surveillance. And probably we are facing one of the most global burden in India currently with this anemia. When we say iron deficiency, it not only affects just the hemoglobin level, it affects the immunity, cognition, and development. And missing iron deficiency anemia, it is like missing a bus for a lifelong consequences. Iron therapy is safe if counseled properly. What we are talking about is just the tip of the iceberg. And we are talking about undertreatment and the cycle of relapse because 2 minutes of counseling while giving the iron supplements was not done properly. And this becomes a latent iron deficiency, which becomes functional iron deficiency, early cognitions impairment, poor school performance, fatigue, weakness, and increased infection risk, and then maternal anemia and low birth stores. This is just the survey which was done in the last survey. I'm probably presenting the same slides what Dr. Amit has already presented, but at a different point of view. So when we see Maharashtra, it is 15.1, which is increase from 2015-16 to 1920. And the proper percentage, if we go to see in every health survey, the severe is increasing, the moderate range is increasing by triple fold, mild has decreased, but overall, if we see 59.1% has increased, we are not overdiagnosing it. And as we see, the maternal source, which is 15 to 49 years of age, it is constantly increasing. And probably that's the reason where the children, six 6 months to 6 years, that is also increasing. 67, we had a decrease in NHS 4, but then again in the health survey 5, there was an increase, and which was a sharp increase. So if we talk about the double burden, it is not just the malnourishment or SAM, MAM we are talking about. There is this study which was done in a very recent year, 2025, which shows that we are having a double burden, which is not only just the malnutrition having the anemia, the normal weight people are also having anemia, and more than that, the overweight or obesity anemia is also prevalent in the child group currently. So it is not just the poor economic social background, even the affluent class has this anemia because of the wrong practice of eating. So if we see anemia overall in the increasing order, it is becoming darker and darker with the underweight, with the overweight and obesity, with underweight and anemia, underweight, overweight, obesity, and the anemia. And if we see not only just the northeast part, even the Gujarat, Maharashtra, and the western part is anemic currently. Probably the double burdens we are not able to see if we are just diagnosing anemia in the underweight population. Now coming to the MBBS parts, as we all know, the iron deficiency has different phases. First phase is where only the iron stores are depleting and hemoglobin is not affected. And then the second phase where there is this first and second phase will be iron deficiency anemia, iron deficiency without anemia. Third stage will be iron deficiency anemia, where hemoglobin and MCV both are affected. The hemoglobin part is also affected. And the functional iron deficiency, which Dr. Amit has already discussed, which happens when there is infection and when there is other sources of anemia prevalent. But if we do not diagnose it in the first and the second part, where the iron stores are getting depleted and hemoglobin is not affected, we are hitting the cognition part of it. So this is known as tissue sideropenia, where iron deficiency in the iron without severe anemia alter the immune cell behavior, reduces the exercise capacity, and impaired neuronal energy metabolism. Immune function is affected, the immunity gets impacted, lymphocyte proliferation, enzyme system, muscle metabolism because of the oxidative metabolism deficiency shifts and less efficient glycolysis happen. Neuronal functioning goes beyond the level, and because of that, there is no dopaminergic system working properly. So when we go into the latent iron deficiency, first part and first stage and second stage, when they are affected and it is not probably diagnosed and not treated, then we only come in the alarming stages when there is iron deficiency anemia. And why this is important? Because then there is no point of return. Definitely, there were animal studies which Dr. Sanjeev already told us that the cognition is affected because the first and second stage were not diagnosed. And that's why the first 1,000 days for the developing brain, when the temporary and the long-term effects of iron depletions have not taken place, this increases depression, anxiety, schizophrenia, autism, and this acts very well in adolescent age group, which has the educational potential also decreases because the iron deficiency was not picked up at the right spot. Now, again, Dr. Amit has given this graph. So, talking about the physiological anemia, which is nadir is 6 to 9 weeks, and we do not give iron. But however, if our 52.2% women in the pregnancy age group, when they're going to become mothers, if they only have the iron stores lesser, and these are the only source of the child having iron, then I think, and the studies also say that the reserve will be exhausting faster than just textbook 6 months. So, if it is really physiological anemia trap or it is iron deficiency because our mothers are anemic itself, and I am not talking about a hemoglobin of 7, we have seen hemoglobin of 2, 3, even medications are given that also they are not working because they are not being given in an order of consistent 3 months or the following dosage. Now, coming to the diagnostic dilemma, which is the ferritin fallacy. Now, if you see this chart has been particularly been chosen because this was the only chart which gave first retic count. And then it gave microcytic RBC, normocytic RBC, or macrocytic. Otherwise, any approach to anemia, microcytic MCV less than 80, normocytic, and MCV more than 80. Retic count, most of the physician or the practicing pediatricians, I have not seen that it is very well into the practice. So from today, I think from debate Dandiya, we take a proper note today that retic count in any case of anemia has to be the first thumb rule, and then another CBC and everything will be taken care of. Now, if you see in microcytic, normocytic, and macrocytic bridges, everywhere ferritin has been definitely put into the picture, and then B12, folate, and everything has to be put in the picture. Now, as we say that, as Dr. Amit has probably pointed out, that ferritin can be a wrong judgment error because if in cases of infection, in any case of cough or cold also ferritin can go high because it is an acute phase reactant. And if you are around the city or in the AQI of whatever 200, 300 we are living, we are always coughing. So in that case, the traditional iron test probably will be a wrong thing to do because serum iron will go up and down in inflammation. Ferritin with the hepcidin block will be variable, and TSATs can be false positive or negative based on the clinical condition and the cardiogenic state. So in that case, we will have to see a better markers for a test of iron deficiency anemia. And coming to the infection, it is a synergistic cycle where infection versus IDA, it is not an either or scenario. Probably in our practice, it will be both infection and iron deficiency anemia. Inflammation with IL-6 will increase the hepcidin production and it will decrease the red blood RBC production, will decrease the iron absorption, decreases the ID level in the body. And probably that's what Dr. Amit was trying to tell us, that it is a wrong marker. But in that case, we will have to believe that we need a proper marker for iron deficiency anemia. And definitely that is the solution to this. Now, coming to the barriers of care, this article was published in 2025 and it is the approach to hemi-equity. Now, this gentleman, this is a very basic
Lisa, we are not able to hear you. Dr. Lisa? Dr. Amit,
amount
can
of
you? Dr.
Hello?
Amit, can you tell
Yes, yes.
us about this hemi equity?
She would be better person to tell.
Yeah, but I think we have lost her voice.
She's
She can
there.
rejoin. I think her net problem is there.
Yeah.
Am I audible?
Yeah,
Yes,
now
yes.
you are audible. Yeah.
Okay, just a second. Yeah. Is the screen visible?
Yes.
Okay. So the heme equity is basically the counterparts. The green part is the facilitator part, and the red part is the barrier part of iron deficiency anemia care. Now, in this, a lot of importance has been given that they were not aware that why they have to take the tablets. If I could just zoom in, yeah. The medical coordinators were not given a proper awareness session. There were adherence problems to the tablets and a little importance for the intervention characteristics, which is the pill blockage and the side effects of it. So, if we tell the mother that to give the medication little far away from the teeth beneath inside, so the teeth staining won't happen and it might cause a little bit of loose motion, probably the adherence will be better. And probably if it iron tablets uh, should be given 1 hour prior or after before food, and not in the combination of calcium. If this is given repeated orders, probably the adherence should be better. And for the green part, the innovation part, the education, community mobilization, which we are doing with Debate Dandiya currently, and healthy mother, healthy baby concept, social marketing awareness, which we have all done for this debate, putting on our statuses and everything, and keeping a regular check, which our ASHA and Anganwadi workers are doing, checking the tablets if tablets are over, again filling up the gap part. This probably will help a community based program which we are doing by 6 by 6 also, the pillars. Now coming to the under treatment and the cycle of relapse. So we all know the optimum response come after 2 weeks of oral therapy, and it is overall response of 6 to 8 weeks. Now what happens is we stop the tablet or the syrup, or the mother forgets that she has to continue. Now by this time only the hemoglobin part has come over, the iron stores have not been replenished. Now to replenish the ferritin store, the oral iron has to be continued for 3 months. We will have to hammer everyone who is taking iron tablets कि ये 1-2 महीने का नहीं है. You will have to complete it for 3 months complete, either 3 months continuously or 52 weekends, which is overall you have to complete 100 days. There is study that 100 days per year, 3 months continuously or Saturday Sunday gives almost the equal amount of iron replenished stored. First thing, the retic count will increase, then the hemoglobin will increase. IV iron FCM currently provides a faster replenishment. If there is failure, if we do not respond, then probably the other causes, and as Dr. Amit mentioned, misdiagnosis or switching to IV iron should be considered then. But proper iron documentation, iron adherence and documentation of retic and hemoglobin should be noted. Now, government has come with this unique approach of Anemia Mukt Bharat, which is currently the need of the hour, which is 6 into 6 into 6 strategy. We have 6 beneficiaries, which is the age group of 6 to 6 years, 5 to 9 years, adolescent girl, woman of reproductive age, pregnant woman, and lactating mothers. And these are the 6 intervention where prophylactic iron, folic acid, deworming, year-round behavior changes, and testing of iron through digital invasive hemoglobinometer, mandatory provision of iron and folic acid fortified food in public health program, and addressing non-nutritional causes and endemic program. 6 institutional mechanisms have been approached to take care of this. I really like the idea of intensified year-round behavior change, where you find the compliance to iron and folic acid supplementation and deworming. Most of us follow 15th August and 26th January forum. and I think all pediatricians like that forum because it is easy to remember for the parents also. Appropriate infant and young child feeding practices. I think YCF is taking care of it in beautiful manner. Increase in intake of iron-rich food through diet diversity and quantification, and fortification probably in the non-thalassaemic and sickle belt, and delayed cord clamping after delivery by 3 minutes in health facilities. I think everyone follows that. So my take on this is high prevalence means we should have a high clinical suspicion. Hemoglobin is a late marker. We should really look earlier before the stage 1 and 2 is gone. And complete treatment 3+1 should be the norm. And thank you. Probably we are all working for healthy hemoglobin and healthy India picture. Thank you so much.
Thank you, madam, for sharing your valuable knowledge with us. And your lecture was very clear and we learned a lot. So now brace yourself as we enter the rebuttal round between both the Dhurandhars. And so I request Dr. Amit Jain sir to start first. Dr. Amit Jain sir, please.
Yeah. So I think I have not seen the prevalence of still iron deficiency anemia in Lisa's slide. We don't know the prevalence of iron deficiency anemia. If we don't know the prevalence, then how can we label the person as iron deficiency anemia without iron deficiency anemia is not hi-fi stuff. With proper history, examination, and even with CBC and peripheral smear, we can diagnose iron deficiency anemia. There is no need to do ferritin. There is no need to do other hi-fi things. With this, we can diagnose iron deficiency anemia, even vitamin B12 deficiency. With the program of iron supplementation since last 50 years, we have rather seen increase in iron deficiency anemia. With supplementation, increase in anemia. With supplementation, if we are seeing increase in anemia prevalence, there has to be some other reason which we should look into it at. And the reasons could be other than iron deficiency anemia. It is prevalent. Actually, anemia is prevalent. So other causes like infections, which is very predominant in our country, we should look at that. Inflammation, anemia of physiological anemia during infancy, which we are actually mislabeling as iron deficiency anemia and giving them iron. Definitely, mothers are iron deficient, but we all learn from our physiology days that fetus is a parasite. Whatever iron available in mother, the fetus will absorb, and fetus will not be iron deficient. This we can check. There are multiple studies which we can confirm with that. And other causes like vitamin B12 deficiency, which is very prevalent. The survey was comprehensive nutritional survey, which was actually from by the government across all age group, including all age group and including all well group population. And they have found that other parameters like B12, folic acid are very predominant. We should address this. If we are giving iron to a B12 deficient person, there is very high chance that the child will develop neurological manifestations and end up in difficult situations rather than treating iron deficiency anemia. So these are my points. Lisa can counter it.
So I see. This is a debate. That's why we are saying it's an overdiagnosis. Otherwise, in OPD practice, we will say the iron deficiency is as prevalent as numbers are. But now coming to it, definitely we don't have a registry of as such for any diseases. Definitely iron deficiency has been not particularly highlighted, and probably because of the population, we will have to give some little excuses to the government that they were not able to particularly point out iron deficiency anemia. But if the prevalence in the society is about 67.1%,
that is prevalence of anemia,
that
not
is
iron
anemia.
deficiency.
That is anemia. Okay, that is anemia. I completely agree with you. 67.1%. Can we at least give it in a global picture when it is more than 50%? Can we at least say 40% is iron deficiency anemia to assume? And there might be another level. They saying that why we are after 70 years of giving iron supplements, we are not able to probably solve the problem of iron deficiency. Probably our earlier salts were wrong. Probably our comprehensions were wrong. Probably the adherence was not there. And probably the folic acid method came in later on. And we learned with our mistake in every national health survey. That's why every time we kept on adding one point with, you know, fortification of food, iron with folic supplements, and then PM Poshan Yojana. So we started ruling out and gathering one step at the time, but keeping the basic cause that the maternal stores and the pregnant and lactating stores were less, and saying that chalo nahi hai hamare paas registry. I completely agree with you, but in that case, can we miss the window of 1,000 days where neurological no point of return might happen because we are not able to diagnose a particular problem? In that case, probably we should not give iodinized salt to everyone. We will just let the
This
fallacy
is
to happen.
no. Despite having CBC since last 50 years, we have iron deficiency anemia. So
Yeah.
look at CBC carefully. If there is no microcytic hypochronic anemia, this is not iron deficiency anemia. Look at CBC carefully. It could be anemia of chronic disease. It could be vitamin B12 deficiency, folic acid deficiency. Even in neonates, if significant microcytic hypochronic anemia is not there, then this is not iron deficiency. I'm not talking about we are underdiagnosing anemia. We are underdiagnosing etiology of anemia. Not we are over-diagnosing iron deficiency anemia. We are not diagnosing only. The
Okay.
issue is that.
So now, when you say that the another cause of microcytic anemia can be thalassemia trait, but aren't we already treating thalassemia trait with iron supplements when they are very, very low? So cannot be that iron thalassemia trait can also be iron deficient with whatever food we are eating and whatever junk we are giving to our children. It can be, both the condition can be coexisting.
Conditions can be coexisting, but without labeling anemia, it is not good to treat with iron. It is better. I'm not talking about doing other investigation. Just see good history, good examination, and CBC. And at
But
the most peripheral
sometimes,
smear.
yeah,
That
but
is
sometimes,
very easily available in India, and almost all the practitioners and pediatricians are doing CBC.
agreed,
Even a pregnant mother is undergoing CBC.
agreed.
Without seeing CBC, if we are giving iron deficiency, giving iron to a pregnant mother who is vitamin B12 deficiency is detrimental to both mother and the child.
Agreed. So that's what the Dandiya debate has said, that we should do retic count also with CBC.
Peripheral smear is enough. Retic count will be low in iron deficiency anemia,
सबके पास
vitamin
अच्छे
B12
पैथोलॉजिस्ट
deficiency
नहीं होते
anemia.
अमित.
No, retic count is not answer to that. Whatever we are debating, retic count will be low in all the etiologies.
Okay.
So now Dr. Amit's point is like Dr. Lisa agreed with Dr. Amit Jain. But now we want to hear from expert. Dr. Rupali Salve, can you please introduce our expert, Dr. Sangeeta, madam?
Yes. To add depth and clarity to this discussion, we now welcome our expert speaker, Dr. Sangeeta Mudliar, madam. Madam is a head of department, pediatric hematology oncology, BJ Wadia Hospital, Mumbai, and she has many publications in national and international journals, and she is a principal investigator in many research projects. So now I request madam to shed a light on this topic.
Thank you, Dr. Sushma. Thank you, Dr. Rupali, for inviting me over here. Thank you, MAHA Academy of Pediatrics. It was a very interesting topic, and both the debaters spoke really well and brought out very important points. The thing that we are overdiagnosing iron deficiency. Personally, I feel it's not. The iron deficiency is very prevalent, and not only iron deficiency is the nutritional anemia, which Dr. Amit also agrees. Like, it's not only iron deficiency, it could be B12 deficiency, it could be other causes of anemia also. So anemia iron deficiency stays an important cause, but this Dr. Amit also said it's around at least 50%, but we have to focus on the rest 50% also. What are the causes of anemia in those cases? Dr. Sanjeev also brought out some very, very important points about iron deficiency, anemia, and supplementation and fortification. I totally agree with you, sir. So we do see, as Dr. Lisa also said, patients still coming with a hemoglobin of 2, 3 with nutritional anemia. The cause being unawareness in the society. The cause being the kind of nutrition what the mother should give to a child. Amit says that baby born will not have a iron deficiency. That's true, Amit. And everybody should know, like as Amit has 2, 3 times mentioned, that fetus is like a parasite. So iron deficiency anemia doesn't come in the first 6 months of age. So anybody putting somebody as iron deficiency anemia on first 6 months of age is not correct. You have to very, very carefully see, unless the mother is very, very severely nutritionally anemic or nutritionally weak, then only the child maybe may have iron deficiency anemia as a infant. Otherwise, the iron deficiency starts after 6 months of age. So 6 months to 2 years of age, when the weaning happens, the wrong weaning happens, the baby is fed on the milk only diet, bottle fed babies. These are the cases where you see iron deficiency. Then at the adolescent age group where you see, but apart from iron deficiency, B12 deficiency is also very, very important cause, and newborn babies also may come with a B12 deficiency. An infant may come with a B12 deficiency. So while we were debating mainly on iron deficiency, other causes of nutritional anemia as important. I wouldn't say Lisa one or Amit Jain one. They brought out very good points in this debate. About diagnosing iron deficiency anemia, one more point I would like to say. Lisa and Amit were discussing on retic count. It is important, as Amit is telling, retic could be low in other conditions like in chronic other illnesses. That is true. But now in the CBC parameters, we also have one more parameter which is called as reticulated hemoglobin. That also needs to be seen, and that will help us diagnose anemia before iron deficiency anemia, before it becomes symptomatic or the hemoglobin goes down. So I have a habit of looking at reticulated hemoglobin as well. Also, Lisa told about anemia and thalassemia minor. That is also a fact. But before supplementing a child with thalassemia minor with iron, it's best to do iron studies. In iron studies, ferritin is important, but ferritin could be high in other it can be falsely high in when there is some infection. So TIBC and transferrin saturation are also important parameters to be looked at when you are looking at the iron studies. Well done, Amit and Lisa. And once again, thank you, Rupali, Dr. Sushma, and the MAHA IAP team.
Thank you, madam, for your insightful expert comment. They added a great value to this discussion. So,
Dr. Sanjeev Joshi has raised his hand. Dr. Sanjeev Joshi, you want to comment? Dr. Sanjeev? Okay, Rupali, you continue.
yes. Before concluding today's evening, I would like to request Dr. Jayashree Deshpande, Madam Chairperson of Bal Sakhi Sanjeevani, to deliver a vote of thanks and to disclose our next topic of debate.
Today's debate Dandiya. Through this Dandiya, today's debate brought different steps and perspective together, but the rhythm remains like
Just
remains.
one pointer,
Yeah,
Jayashree,
Dr.
one
Sanjeev, yeah.
pointer. Actually, Dr. Lisa and Sangeeta madam, if you consider the first 1,000 days and the code which I was referring about 6 months and up to 3 years, the source of the preparation of the iron which were supposed to be given for this age group, they were not at all palatable. Is till recent time how can you give? How can the parent give a tablet to a baby of 1 year or 1.5 year? And if at all you are giving something as a medicine, parents are going to stop it at some or other time. They are not going to give it for 1,000 days, which is mandatory for the brain development. So that's why the need of the hour is the fortification in a vulnerable uh, 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 population. Actually, Government of India has started fortification as a pilot study. The floor which was given through the PDS system in few states, but I don't know whether it is there in Maharashtra also. And but my point is that the fortification remains only the answer to challenge this iron deficiency in that particular age group, 6 months to 3 years. That's all. And excellent by Dr. Lisa, Dr. Amit, and good wrap up by Sangeeta. So signing off. Thank you so much.
Yes, thank you, Dr. Sanju Joshi. Your perspective is very much important. And in this debate, Dandiya, we maintain the rhythm, which is prevention, awareness, and better child health in today's world. चर्चा इथे संपत नाही, तर इथूनच प्रतिबंधाच्या सुरुवात करूया. आजपासून आपण सर्वजण we would like to do, as Dr. Sangeeta madam told us, that we have to do the reticulated hemoglobin. Along with other tests, we will advise all the patient who we are suspecting iron deficiency. Then what Amit Jain told, that it's only 50% of other causes are there, and we should look for the other causes of iron deficiency, not only anemia, but other causes for anemia, not only for iron deficiency. And even below 6 months, the important thing is that we are supplementing these children with iron, which is actually not much needed unless there is a proper diagnosis of iron deficiency. And I always liked Dr. Lisa's slide, which was heme equity. It was very much informative, and thank you so much for sharing this slide with us. And as everybody agreed that there is a communication gap between the patient and the doctors, and the proper markers for iron deficiencies we are lacking. And also we have to keep a register for proper diagnosed iron deficiency anemia. So we have learned a lot in today's session. I sincerely thank Dr. Sushma Save madam and Dr. Rupali for taking this up topic very well. I'm really thankful, and I have a sincere gratitude to our um, President Dr. Sanjeev Joshi, our VP Dr. Amol Pawar, and Dr. Renu Boralkar Madam, our dynamic secretary, for giving us this opportunity. I am blessed to have speakers like Dr. Amit Jain and Dr. Lisa Bulsara for this topic, and you had given full justice to today's debate. We enjoyed the rebuttal session very well and learn a lot in this session with Dr. Sangeeta madam's perspective. Thank you, madam, for sparing time in spite of your throat problem. And at last, I am really thankful for the webinar is meaningful when the minds connect and meaningful learning is there. And I am really thankful for all the audience who are there in this today's debate Dandiya. I am thankful to Dr. Mrs. Pallavi for giving us the support for this Zoom meeting. And the next topic for our discussion and the debate will be on obesity. We will be meeting on the second Saturday from 9 to 10 p.m. Every month from henceforward. Thank you so much. Thank you.
Thank you. Thank you.
Thank you so much.
Thank you.